All right, this is our final symposium. We're going to discuss some controversies in posterior spinal surgery, so we have some phenomenal speakers and should be entertaining. So our next talk will be Dr. Liu, hybrid constructs, laminoplasty, and fusion.
Thank you very much, Chairman. Before I start, I would like to thank CSRS and our president, and also Dr. Woods, and also Dr. Savage and Dr. Bisson for the kind invitations. When I was given this topic, I'm wondering to myself, why laminoplasty and fusion? As we know, laminoplasty, the benefit is to maintain motion, and fusion eliminates it. So current strategy for anterior surgery or posterior surgery for myelopathy, depending on a number of different factors that you're familiar with, but many of us will probably do a posterior surgery when there's more than 3, 4, 5 levels of cord compressions. And in order to avoid the anterior surgery high complication rates in that, there are other factors as well, for example, patient factors and surgeon preference to a certain extent. So my go-to method for multi-level of spinal cord compression is a C3 dome, C7 reverse dome, open door laminoplasty. We prefer to maintain motion as much as we can. But there are situations that I will do laminectomy and fusion. For example, when there's a not favorable segmental alignments problem, regional alignment problem, and global sagittal alignments problems as well. And certain type of OPLLs perhaps may also affect the decision making. Long time ago, we reported Dr. Ru's revision result for open door laminoplasty, which occurs around 9 to 10%. And majority of that time was disease progression to a certain extent, some technique related, but some of them are actually inadequate treatment, such as foraminal stenosis and segmental kyphosis within the laminoplasty. We all know about the K-line. If there is a K-line negative lesions, which is a line drawn from the center of the C2 canal to the center of the C7 canal, the lesion passes behind it, K-line negative, those lesions, you cannot do laminoplasty. It will fail. And for those, the author have recommended if you need to do a posterior, then you need to add fusion in order to eliminate the motion for that. We know if there's a C2, C7 SVA in more than 4 centimeters, Sakai have told us laminoplasty is going to fail. And also, similarly, we noted that if there is a T1 slope, as well as cervical lordosis mismatch more than 20 degrees, again, laminoplasty is going to fail. How about global sagittal alignment? Go Yoshida talks about if you have a C7 SVA more than 5 centimeters, and then even though it looks like radiologically there's a lordosis, laminoplasty will fail. And as a result of that, they recommended if it is more than 4 levels, you go posterior laminectomy and fusion for that matter. Some OPLL, you might want to consider laminectomy and fusion, particularly the meta-analysis that demonstrate it slow down the progression of OPLL and maybe reduce recurrence of the myelopathy. So in this particular case, it's K-line negative patients, and that's what we do, the standard lateral mass screw and laminectomy, and then that's just about it. The results of the laminectomy and fusion is not too bad. In this meta-analysis, surprisingly, it quote up to 98% of the fusion rate with minimal revision surgery for that. But if you look at this one, Dr. Lee and Dr. Ru have highlighted that if you have a propensity match of 3 levels and above, using anterior surgery, laminoplasty and laminectomy and fusion, they have reminded us that the laminectomy fusion carries the highest risk of morbidity, complication, and mortality for this patient. Taking a closer look of another meta-analysis, what type of complication laminectomy and fusion may occur. Maybe they have a higher rate of C5 palsy compared to anterior surgery and laminoplasty. Maybe they have higher pseudoarthrosis rate, which is about 20% or so, dural tear, and also implant-related problems such as PJK and DJK for that. Currently, in laminoplasty, as you all know, we can do open door Harabayashi techniques and French door Kurokawa techniques. The question is really, what can one offer by having a lamina in the laminoplasty in terms of fusion? Well, the first thing come to mind is actually enhance the fusion bed as compared to laminectomy and fusion. Most of the laminectomy and then the fusion mass occurs in the lateral mass, which is already small enough, and most of the lateral mass is occupied by your screw anyway. So this is going to make fusion a little bit more difficult. And if you have a better fusion, maybe you have a lesser axial neck pain and maybe a lesser implant loosening and leading to failure and leading to deformity happening. By having not touching the dura with the lamina there, you may reduce the dura tear. And by having the lamina there, you may prevent something called the post-laminectomy membrane syndrome. And also, by having the lamina there, sometimes you may block the cervical cord migrate posteriorly, excessively, to a certain extent. And as a result of that, for those who believe in tether cords nerve root problem, that may reduce C5 palsy. So this is an example of a C3 dome, C7 reverse dome open door laminoplasty. And if you look at the post-operative, the MRI showed that this is the amount of dorsal cord migration that you will see. In a C5 palsy patient, and then after laminectomy and fusion, you see there is a little bit larger amount of dorsal cord migration is being noted in here. In the early published laminoplasty and fusion techniques is mainly used for trauma, and they use lateral mass screw fixation for that. And subsequently, you can use pedicle screw fixation. You can use a combination of this. And in my practice, sometimes I will use a pedicle screw and a laminoplasty plate, and maybe just a longer laminoplasty plate screw for the fusion to occur. In the literature, the reported literature, the current indication for laminoplasty and fusion has been mainly instability, trauma, maybe athenoid type of cerebral palsy, stenosis, again, more instability, and of course, some of them OPLL with reasonably good outcome as quoted in their papers. Others have suggested to use selective fusion within the laminoplasty to eliminate segmental instability problem to enhance the outcome in that. By now you're wondering, okay, I have an open door laminoplasty, I may have a plate there, how am I going to squeeze in a screw inside that? Well, this paper Nan Soon have talked about, is it okay to do a unilateral lateral mass screw fixation together with an open door laminoplasty in a small cohort of patients. So this is an example, 62 years old male with central cord syndrome with potentially C5, 66, 7, this problem. So what we decided to do is a C3 dome, C7 reverse dome, open door laminoplasty. But for the instability part, we add a pedicle screws in order to stabilize it. In the degenerative cases, this is an 81-year-old man with a C1, C2 instability and multiple subaxial spine cord compression. There is also foraminal stenosis as well as sagittal alignment problem and osteoporosis. So in this particular patient, we decided to do fusion, and then after we stabilized the long segment, in order to enhance fusion, we decided to do the C7, C3 dome laminoplasty, and then to enhance the fusion bed, and also with the hope that it might reduce C5 palsy. And luckily, this patient have no C5 palsy after that. And of course, we can also do it with French door technique using pedicle screw, as Dr. Nagata have shown us in this case, and also use it in lateral mass screw as well in this area. And Dr. Kenta have suggested the use of fusion in laminoplasty as a salvage techniques after that. This is a case that where they have developed post-laminoplasty kyphosis after 5 years. And you can see that the implant is still there, and then open door over that area. And what he have decided to do is correct the alignment by using lateral mass screw, and then in the most severe area, they do a laminectomy, but keeping the remaining laminoplasty intact like that in these particular patients. Finally, as the indication become expanding, in China, Professor Sun Yu have talks about the use of a new type of plate design in order to do this type of work. So you can see this is like a classical laminoplasty plate, but yet there's a bigger hole which allows you to put a 3.5 screws on it. May it be a lateral mass screw, may it be a pedicle screw, depending on what you want to do it. But the opportunity is that the screw can now allow you to put a rod next to it and further enhance your fusion's stability over that area. So in summary, when there is more than 4 levels of cord compression, my go-to method is a motion-preserving C3 dome, C7 reverse dome, open door laminoplasty. I will change it to a laminectomy and fusion when there's instability, particularly canine negative patient, maybe with sagittal not favorable patients, and certain type of OPLLs. And finally, I will consider fusion at a laminoplasty when I think there is poor fusion bed that. And high risk of non-union, maybe potential high risk of C5 palsy development, and potentially adding it as a selective fusion in laminoplasty or even the salvage techniques. Thank you very much for the opportunity and time. Thank you.
All right, we'll open up for questions. Those were all excellent talks. Thank you, guys. And thanks to Barrett for organizing them. So questions? Dr. Patel.
Great. Yeah, thank you again for everybody. Fantastic symposium. It's probably a question for the whole panel, was around wound closure, the topic around wound closure. And we talked about some good adjunctive techniques. Has anybody changed their actual closure? Many of us know Dan Rue is one of our former CSRS presidents and talks a lot about the closure technique being really important. So what do we do with closure? Types of suture, layers of closure?
So I'm not one of his fellows, but I've had fellows who have been his trainees. So I now pretty routinely will put, not in 3 muscular layers, but certainly some kind of small bite, just 1 ovicral sutures for the muscle. I mean, it's undeniable. The nuchal ligament has to be perfectly reapproximate. If you miss that, that wound's going to splay. So for us, we use obviously deep drains. I told you we do betadine and vancomycin. Then muscle approximation, numerous small bites, just to approximate it. You don't want to necrose the tissue, obviously. Not necessarily a layered muscular closure, but muscle, nuchal ligament. If they're really big, they get a superficial drain too. And then closure with an IVAC.
Dan, you want to comment?
Yeah, nothing to add. I agree. Some people are looking at permanent sutures in some of these nuchal ligaments, so you avoid the popping of that suture 1 month out and then the splaying. I'd also argue, just to throw in the measurement stuff, if you end up closing it when it is kyphotic, that is a higher risk. So understand that if you're stuck, you're stuck. But if you can get that patient back, seeing that nuchal, all those ligaments come together is much nicer versus it being under tension as you close.
Yeah, I love the idea of a mesh suture. Maybe Gabriel, I can ask you as well. When I've had a chance to visit the CSRS AP meeting, there's a lot of talk that we don't have here around muscle sparing or muscle preserving approaches to the posterior cervical spine. Can you give us just a little bit of insight on how that might help solve some problems we talked about today?
Yeah, thank you very much. And then, as you know, in Asia, we are going through a kind of a revolution at the moment. And then there's a lot of endoscopic surgeons coming up. So they will try everything endoscopic. Some even tried, there was one case that they have an odontoid mass. They tried to do endoscopic from posterior to go to in front to reduce the endoscopic. So we are still trying to sift through the information. But in general, for wound closure, I would do exactly the same as what you guys have talked about. I visited Dan a long time ago, and I still use 4 or 5 layers closure. And one of the things to highlight in the wound closure is that probably the wound closure starts at the beginning and you do the dissection. Right at the beginning, if you don't get the right plane to start with, you can't close it properly in the beginning. Going back to the question in terms of wound and endoscopy, they are now trying to do endoscopy for amniotomy, which I understand, but they are trying to do endoscopy laminoplasty, which I'm trying to understand, and then the only problem that we face in endoscopy in cervical spine, nobody really talks so much about it, but there's some whispering, is the fluid pressure. And then that by itself can cause drop of MVP and causes long-term problem. Thank you.
I want to thank Barrett again for organizing it and all the panels. Those were excellent talks. Thank you guys very much.